And now I would like to introduce my co-presenters today. We have Ann Massey. She's the Director for Health Equity and Sponsored Programs in the Office of Health Innovation, and Dr. Kevin Harris, who's the Associate Vice President for Strategic Initiatives and Engagement in the Vice President for Health Science Office. And he is also the new Interim Senior Associate Dean for Diversity, Equity, and Inclusion in the School of Medicine. So Kevin, I'll give you the mic.
Thank you, Logan, and certainly good to join the stage with you and Ann again, and certainly welcome all the colleagues who've joined us for a discussion about health equity and how we are as an institution combating or addressing the issues, but also what's kind of happening in the landscape and around us that are impacting your education experience or even your teaching experience right as we speak. I'm going to actually start us off with just some definitional pieces. You know, words matter, concepts matter, and it's important to really begin to understand, you know, where a situation or a challenge is rooted, if you have any hope of addressing it. And so let's start with this concept of equity. Now, many of you or some of you may have heard of the concept of health disparities. And I first want to just quickly draw a distinction between health disparities and health equity. Health disparities certainly is an important body of work. It begins to understand and isolate those differences in health outcomes, particularly along issues of race and gender and socioeconomic status. It sort of shows the disparities or the differences that are occurring that are outside of what we would want and expect to occur. They're essentially unnecessary differences that could be caused by a number of factors. Again, very important work and provide us with very important metrics to follow and understand. But when we start talking about equity and health equity, we move into a space where we're again talking about this issue of equity and inequities, and issues of inequality and equality start to surface as well. And again, very important concepts, but very important to distinguish between the two. And this graphic really illustrates for us the nuances between these terms. So when we're thinking about inequality, right, the ability for individuals or inability of individuals to just have access to the same things. They're just provided at a fundamental level in different ways, right? So that's clear and understandable that that's not a good place to be, whether it be in healthcare or any other arena, quite frankly. And so some would suggest that then the opposite of inequality is equality. And we'll talk about that a little bit later. There's an argument to suggest they're not opposites, but equality at least starts to get you to that place where at least you feel that individuals are getting the same thing, right? And for many individuals and organizations, that is essentially the goal, right? Is that we provide the same thing to everybody, all right? But let's begin to think differently about that. And this is where equity comes into play. So equity, quite frankly, begins to dispatch between this idea that equality is the opposite of equality. And what equity begins to show is illustrated in this diagram is that it's about individuals getting what they need, right, according to their situations, right? And so it's not getting the same thing, it's getting what you need. And that certainly gets us closer into a better position. I would even argue that even equity then is not the opposite of inequality. I would say this concept of justice really begins to get us to address what we mean by addressing inequalities. It says, yes, equality is not going to get us there. Yes, equity is very important, and at least it begins to solve the issue. But to really get beyond it, you really have to have some structural change, and you really have to begin to shift the landscape itself to ensure that the equity that we want people to have is available to them in a continual way. And so it's important for you all to really, particularly as future health professionals, to really understand and parse those terms because your solutions and your behaviors and your actions are going to be dictated by how you conceive and perceive of these different concepts. Next slide, please. And so just briefly, when you're thinking about health equity, an important framework or concept to understand is social determinants of health. And I won't spend a lot of time on this. We have a lot of territory to cover, but the takeaway from this is just to understand within the clinical environment, within the healthcare clinical environment, regardless of what your profession might be and how you contribute, there's only about a 20% contribution of what you do in that clinical environment toward addressing the issues that a patient or patients may have, right? There's some 80% that's out there, and you'll find different reports that will vary in terms of what their percentage is, but at a minimum of 50 up to about 80% of what an individual has impacted them in terms of their health is actually being influenced outside of their clinical experiences. Now, this doesn't diminish the importance of clinical experiences, but it does put it in a different perspective. And so when we begin to think about, well, what are those things that impact us, impact our health, before and after we go to a doctor's appointment or a nurse's appointment or a dentist or what have you, and you're looking at economics, you're looking at your environment that you're in, you're looking at your education levels, right? You're looking at your access to food, not just food in general, but healthy food. You're looking at your community and social context. You have social capital to navigate systems. And then certainly even the healthcare system beyond the clinical piece, some other surrounding factors in terms of provider availability, how they, in terms of cultural and linguistic competency, those factors also impact your health outside of the clinical experiences. So that's just touching on these concepts. I'm going to turn it over to my colleague, Logan, who will now walk us through what's happening in Virginia with respect to health equity and social determinants of health.
Sorry, I had to unmute. Thanks, Kevin. All right, I'm going to take you to this slide here, and what we are seeing is Richmond. At the bottom of the slide is the James River, and to the right-hand side is the highways, 95 and 64. So that right-hand side is East End, and then more over to the left is where VCU and the West End of Richmond is. So I'm just going to take you through the slide from left to right. So food access. 50% of the census tracts in Richmond City qualify as food deserts. Health outcomes. In 2014, Richmond City ranked in the bottom 10% of counties in Virginia for health outcomes. Well, that hasn't changed. In 2019, we were still in the bottom 10%. And that is in contrast with the counties surrounding us, such as Richmond, Chesterfield, Henrico, New Kent, Goochland, Powhatan. They all rank in the top 25%. And outcomes are referring to how long people live and how healthy they feel. And so within the poverty rate, the next one that we're seeing is within the city of Richmond, the poorest census tract, the income is 17 times greater difference between the poorest and the wealthiest census tract. 17 times, that's a lot. Education, more than 1 1/4, 25% of the city's African-American adults and 59% of Hispanic adults have less than a high school education. And that's in contrast with only 7% of white adults. In poverty, we see the 1 in 4 number again. 26% of the city's residents live in poverty. Race. Highway construction and public housing isolated neighborhoods by race, while socioeconomic conditions, often stemming from discriminatory policies and practices, prevented relocation. Persistent segregation resulted, and African Americans in Richmond City are far more likely to live in poverty, suffer from preventable diseases, and die younger than whites. So you can see the results of systematic racism. I want you to notice with the highway that there is a white man on the left-hand side of it and a black man on the right-hand side. That was very intentional, that the highways went through the black neighborhoods of Jackson Ward and Carver, and it divided the communities and concentrated poverty. And in areas with concentrated poverty, you're more likely to have chronic heart and lung disease, diabetes, obesity. And so you couple these with the fact that socioeconomic factors are really hard to change on their own. And then on top of that, you add COVID-19. And we just have a recipe for a hard storm to come over. And I just mixed up so many metaphors there. But anyway, so you put COVID-19 on top of this, and you look at folks in our vulnerable communities, and they could be more likely to have a job that exposes them to a lot of people, such as they could work in frontline healthcare or retail. They could rely on public transit to get to work and not have and they have limited ability to get PPE, masks, hand sanitizers. And their neighborhood could lack grocery stores with healthy food choices. So what we're seeing is in our vulnerable communities, the folks that are more exposed are also less protected. So they're getting more infected, and they are already more burdened by chronic disease and access to healthcare. So there's just a higher mortality rate. And so this next slide is another look at mortality rate. You can see on the left-hand side, on the bottom is the James River again. We have 64 and 95. So the top right-hand corner is the east end. I want to draw your attention to Gilpin Court. The life expectancy there is 63 years. You travel just 5 miles south to the left-hand side in Westover Hills, and it's 83 years. That is a 20-year life discrepancy difference. So what can we do about this? Where do we start? Where do we focus? Well, in Richmond, we've been lucky that there have been a lot of community needs assessment. We've done a pretty good job of identifying our priority areas. The Office of Health Innovation looked at over 20 different reports, and they kept coming up with these top 3 priority areas across the board. And they were food security, or food insecurity, housing, and transportation. So at VCU, we have chosen to focus on those. And why is that? Well, if we look at this slide on housing, it says the percentage of households with at least 1 of 4 housing problems is 25%. Again, the same as the poverty rate. And a housing problem is defined as overcrowding, high housing costs, or a lack of kitchen or plumbing facilities. Again, the counties around us are doing much better than the city of Richmond. Okay, this slide is transportation. You can see in the East End that upwards of 30% of residents are relying on transportation to get to work. And then this slide is talking about food. Food insecurity is defined as a lack of consistent access to enough food for an active, healthy lifestyle. And a food desert is when 20% of the population lives below the poverty line and 33% of the population lives more than a mile from healthy, affordable food options. You can see the blue is all the food deserts in Richmond, and at the far right-hand side, you can see how we're concentrated in the East End again. So that is the data, that is the cause for why we need to take action. And I'm going to turn it over to Anne, and she's going to tell you about what VCU is doing.
Thanks, Logan. So you're just going to spend the next few minutes just talking through how VCU, both the university and the health system, are addressing these health inequities, both for our patient population and for the community as a whole. And so what we're looking at here just is really a snapshot of those efforts, and it really encompasses about 4 years of work. Granted, we've been modifying this as we go and making adjustments. It certainly hasn't been static. But this really got underway in 2016 when Marsha Rapley, who at the time was the CEO of the health system, really articulated her vision for how to improve the health of the community. And she specifically requested the development of a health equity strategic plan. And when we started to kind of put that together and try to figure out what that would look like, we really wanted to structure it through our kind of key mission areas. So along the top there, you see research, and then on the right side, patient services and training and education. Those were kind of like the three initial areas that we really wanted to make an impact through. We also, at first, had a separate group for community engagement. However, when we were developing the plan and vetting it with our community partners, some real clear feedback that we got was community engagement should not be on its own. It should not be in its own box. It needs to be really integrated throughout everything that we do. And so we heard that, we made changes, and we really broke down that particular thematic area. And instead of having a community engagement group, we moved forward with our research, patient services, and training and ed, and we had it designed around two co-chairs, one who was from VCU and one who was representing a community-based organization. So that was a real intentional way that we wanted to make sure a community voice was always at the table. These groups roll up to a health equity steering committee, which again, same thing, co-chaired by someone from VCU and someone from the community. And we also added an innovation work group last year that was really in response to an initiative that we're working on with the Coalition for Urban Serving Universities to really bring some efficiencies and innovation into some of the clinical workflows that we're looking at through our work. And so one of, or really the biggest project that came through this first line of groups really launched in May of 2019. We started a social determinants of health screening and referral pilot program on the North 5 unit of the hospital. That's an adult general medicine unit. And it was a model that was really built around the integration of an outreach worker into the workflow who could screen patients for any health-related social needs, particularly, like Logan was saying, we're absolutely looking at food insecurity, we're looking at transportation, we're looking at housing, but we're also trying to understand if there are other needs, because we know that health-related social needs don't occur in a silo, right? So there's oftentimes multiple needs occurring at once that may not fall into those three categories. And so the outreach worker is really able to assess for those and then make warm handoffs to the appropriate community partner. And one of the things that is different about this pilot is that we actually had our community partners at the table from the beginning. So as we even started to think about this pilot and what it would look like, we asked representatives from Feedmore, from Homeward, from Round Trip, which is a transportation, they provide transportation benefits through ride-sharing programs. We asked them to the table so that we could understand how we could best move forward with them in partnership, what kind of referral mechanisms work the best, how we could get kind of closed loop feedback. And so we wanted to make sure that we really had their voices at the table. We also undertook a pretty comprehensive educational effort at the onset of this pilot. We worked with our training and education work group on this to make sure that everyone on the unit had access to either an online or in-person training that really laid the groundwork for health equity and also described the pilot. And lastly, something that's different about this pilot is that we made sure that the results of these screenings that happen on the unit are incorporated into daily flash rounds, which occur with all of the whole unit, all of the medical providers, to make sure that the results of this screening are factored in when medical decisions are being made. And so our goal with that pilot was to really reduce readmissions, reduce hospital inpatient stays. We wanted to increase provider satisfaction, increase patient satisfaction, and we've been up for a little bit over a year and we've been seeing positive results. And so that has been a pretty massive undertaking from a lot of the groups that you see here. The second part of this chart that you'll see really relates to COVID-19. And so obviously these groups are pretty fresh. We just got these launched this spring, really, when we, obviously like everyone else, we're starting to see and understand the significant racial health disparities that were being exposed by the pandemic. And so in terms of our organizational institutional response, with the leadership of Kevin Harris and Cheryl Garland, put together more groups, again, not just VCU, but in partnership with the community. So put together a health disparities task force and then chose, again, kind of thematic areas where we wanted to try and make an impact. And so through education, through telehealth, and through those partnerships with the health district and our other safety net providers, wanted to see how we could try to mitigate the impacts that we were seeing. And so a lot of work's been happening here. I'll just give you a couple quick examples to kind of let you know some of the results that have yielded from this work. One is the Latinx education work group that really came to be after we were made aware of a pretty significant gap that existed in appropriate written and audio materials available in Spanish. And so a group that has many community partners at the table, as well as VCU reps, have been meeting regularly. One of our biggest partners in this area is the Richmond City Health District. And so we've been working in close partnership with them to brainstorm how to reach our Latino population. And some of the ways that they are doing that are through radio spots. They are working on developing educational videos that'll be available through social media and online. And they've also really made an effort to create written materials that are in Spanish or largely in pictures. And so they have been very busy. Another group I'll draw your attention to on the right-hand side is the PPE and supplies work group. This group was very busy in the spring, really trying to identify what the needs were in terms of community members who needed things like masks, as well as organizations who needed PPE. So again, worked really closely with the health districts, worked with other organizations like the Community Foundation, and really worked to leverage our purchasing power along with these other larger anchor institutions so that we could provide masks to group homes, to other places like Health Brigade, where they were ready to go for free testing events, but lacking the essential PPE in terms of masks and gloves. Once we provided that to them, they were in turn able to go ahead and hold their free testing events. So again, this work is in particular is very evolving, very busy right now, but just a couple examples of what that work has come to. With that, I will turn it back to Logan and Kevin.
Well, thanks, Ann. And so, so what does this all mean, right? So again, we're in a confluence of events that I think Ann used the word expose, that really is, I think, exposing some of the underlying challenges that we face that are just continuing to facilitate and actually fuel the inequities that had already existed within our communities. I think about some conversations we've had, particularly recently with seniors, as we're trying to address the COVID situation, and you begin to very early, understand in those conversations the impact that this has when there are already things on the table around isolation, around maybe being less mobile to reach and access resources, having health issues that are likely more acute in some cases. And on top of that, you then lay a pandemic, which creates all other kinds of stresses and pressures. And you begin to understand when we talk about these non-clinical factors that influence your health and continue to impact your health even beyond what you might get as treatment, how important it is for even practitioners to appreciate and to factor in those external concerns and situations as you're delivering your care. One of the prime examples, of course, is around medication. So, an individual's or treatment plan for a particular illness. And you realize, or you don't realize, that as you send that person out with what you think are the best instructions, the clearest instructions, I mean, you've done your best, you've trained well, and yet they leave, and in many cases don't have transportation to even get to the resources you pointed them to. Or when they leave, don't have a stable home situation or a home at all in some cases to go to. Or quite frankly, you don't have access to food and nutrition in the way that would actually facilitate their reaching their optimal health. So what at VCU we've decided, along with a number of other organizations across the country, is that it is incumbent upon us to also think about that 80% that in some cases we might have felt we aren't responsible for. That is incumbent upon us to address that as well. I mean, there have been scenarios where health systems have purchased housing complexes to provide to patients who had unstable housing. And you would say, why in the world would a health system get into the real estate business? Well, understand, it doesn't behoove you to have your patients in a revolving door, back in and out of your emergency department, And the issue that they face is that they didn't have a stable place to lay their head to even get the rest that you prescribe. So again, that's why this is important for practitioners, for health systems, and for communities to think beyond and think of all the factors that are influenced. So with that, we'll stop here and engage you all, hopefully in some great dialogue. And as Ann and Logan mentioned, please use the chat box to ask questions that you might have in your head, and we'll do our best to respond or point you to resources that can get you the right response.
And so I was curious in the slide that Ann touched on about the OB postpartum work group. I just wanted to hear, I think that a lot of information has come out recently specifically about just the inequities among deliveries with women of color and just the delivery complications and the deaths that happen in the OB scene. So yeah, I was just wondering if you could touch a little bit on what you guys are doing. I'm just very curious about that.
So that one, I think, also has, that group has also focused a lot on some educational and outreach efforts. I can do some more looking into that one for you to get you some more specifics on it. But I know that, again, that same theme of education has been part of it, and really getting the word out on appropriate resources for moms and postpartum moms has been a key to that one. But I can definitely get some more specifics for you on that particular group.
Yeah, that would be awesome. Thank you.
Yeah, Susanna, it's important to note, again, we started that sort of hierarchical chart that Ann showed you. The COVID space really grew exponentially, and it was organic. It literally started with a conversation from a colleague as information was coming out about the disparate impacts of COVID on African-American communities in particular. I think very early in Richmond, the entirety of deaths, and there were, around 15 to 20 or so, but the entirety of deaths from COVID were actually African Americans. And that created this alarm, right, and recognition that, wait a minute, we're having some disparate impacts. COVID is not, it's an equal opportunity virus, but it is finding its pathways in underrepresented minority communities at a much faster pace. And so that sparked a conversation, and it said, what can we do about it? And it was just that informal, like, what can we do? And from that, we began to just pull in individuals and networks that we had. And before you know it, it branched off into areas. And the OB conversation was another offshoot. As we pulled experts in the room, that conversation naturally began to gravitate to, well, what else is happening? Is there another group that's being impacted? And so that's going to continue to blossom. That's going to be a sort of a flower that continues to grow as COVID continues to, again, expose some challenges that we even had before COVID came about. But thanks for that question, Susanna. Really appreciate you stepping in on that. So let's grab someone else. Hi, Deshonda, how are you this morning or this afternoon? You have a thought for us?
Hello, I'm fine. So I'm a third-year PhD student in the epidemiology department, and I'll just say I used to work at VCU in a genetics lab. And so I think one thing that's important is to really emphasize to medical professionals and healthcare professionals about the role of the social aspect of race and racial assignment, and that differences are not biologically based. I still think that's being emphasized and taught in programs. And I know when I worked in a lab, it was just not, the social aspects of it were not discussed. And the racial assignment, social, and how it was deemed socially and not biologically is not discussed enough. And I think that that's one step and one contribution that we can really emphasize to help reduce health inequities.
Deshonda, I appreciate you. And actually, we may have even been guilty in some of our descriptions, and you're absolutely right. I've been listening to James Baldwin, pulling up his interviews and speeches, and it's really been therapeutic for me. unfortunately disappointing because we're still really dealing with issues that he described, decades ago. But what's been therapeutic is just the language that he's giving to these issues. And one of them, again, is calling out racism and reminding us that race is a social construct. There's no biological relevance of the concept of race. We're more in common than we are different. And yet it sort of, is prevalent throughout much of our medical dialogue and discourse. The fact that somehow an individual's, quote, race is the reason why they might be disparately impacted by something. And so thank you for pointing out that it is so important to be clear about the impact of racism and other isms on our health and our livelihood. Appreciate that, Deshandra.
Thank you.
Yeah. Takia, how are you this afternoon? You can go in and click.
I'm good. Sorry. How are you? There's a lot of other people around me, so there's a lot of background noise.
No, you're fine. You're fine. What do you have? You might have a question. You have a thought. Did we need to cover it? How did we do? Did we give information that you think is useful?
Sorry, there's someone talking in the background still.
We can hear you. All right, the key is
Sorry, people are moving. Just give me a second. Okay. No, I thought all the information was really good. It was a nice overview. I haven't seen that kind of workflow before, so I thought that was really good to see and learn about a little bit more about what VC is doing.
Yeah, no, it actually, and I think the point from that, to be honest, is, these are systems that we are putting in place. These relationships, the pivot to COVID was really a case study on why community is important. And I don't want you all to miss that fact. When we initially launched the Health Equity Initiative over some 4 years ago, and the community instructed us, quite frankly, that we need to have community engagement threaded throughout the initiative. That was the best sort of structural change that we made, and really positioned us to then be a resource in this COVID pandemic. Had we not established those relationships, had we not built a trust between us and our community members, had we not known who the players are, when COVID hit, I don't know if we could have been as an effective resource, but we were able to quickly, within weeks, pull together a network of individuals. And there's nothing magic about VCU. It was the fact that we just happened to know a lot of people and have worked with a lot of organizations. And they are the they're the secret sauce in this. But because we built a community and we built the networks, we were able to leverage those quickly to then deploy and help individuals and organizations as they were experiencing tensions and challenges. So for all of you all, if you take nothing else away, understand that there's a collective impact that can only be had if the time is taken to nurture strong community organizations. As you move into your practices, get outside of the walls of your health system or your doctor's office or whatever office you're in, and go out and get you some resources in the community. You will just never know how those will pay dividends once you come across patients with different needs. So that's the lesson we learned out of that. But thank you for pointing that out, Takia.
There's a question in the chat that I just wanted to share from Whitney, because we haven't had the chance to call on her yet.
I was getting there.
What recommendations do you have for students in understanding how to navigate politics within our community and greater society at large that have prevented the implementation of solutions that can help us to achieve health equity?
I've been doing a lot of talking. And Logan, if you want to take a stab, I got some ideas, but I'll defer to you all.
Well, I think one of the things you just hit on was the relationships with community partners. I mean, I think that has been hugely important with us being able to navigate some of these larger issues that have come up quickly and nimbly.
Yeah, yeah, yeah. The relationship is important. Under sort of pinning that is this idea of trust, though. You have to do the work prior. You can't just show up at certain times and just think individuals are going to just automatically trust that you're there for the right reasons, or that you bring the right sets of skills and resources to even be of help. I learned firsthand growing up in Gilpin Court for a few years, and having literally remembering VCU coming in with different initiatives and ideas to, quote, help us in the community. And I'll be honest with you, at a very young age, the one thing that we realized and came to expect is that they're not coming back. They're not going to be here when we really need them, right? This is, they're checking a box, trying to get a grade or trying to, further their own agenda. But unless you build trust, which means you're going to have to show up consistently and show up earnestly, and not come with solutions, but come and hopefully be a part of solutions, then it's going to be very hard to engage the community in the actual event. And that's what we're going to face with this COVID issue and with like vaccines. And, you can't just launch something out and say, trust me, it's good for you. They're going to need people who they automatically and already trust. And so as practitioners, build those relationships before you need them, because if not, you won't be able to have them when you need them.
Go ahead, Whitney.
Did we lose her?
Oh, no, I'm here. I was just saying thank you for your responses. I agree. I agree with the importance of trust and establishing and maintaining effective partnerships with the community that we're serving and partnering with and working with.
Yeah, yeah.
I did have, while we have a pause, I will just say I was able to locate my notes, Susanna, on the actual kind of some more specific examples of what that OB group has done to let you know how they're getting the educational messages across and what they're doing. And so they've done a lot so far with more video content. So they have created a video on the Spanish YouTube channel where they're interviewing some of our providers. They're working on a Facebook Live session. They've also put together some FAQs, and I know they have a continuing working group that's looking at how to identify gaps in care and potential solutions. So just wanted to kind of give that additional context to what that work group's up to.
Thank you. That's very helpful. I think, I guess I was just curious, and I'll have to ask to see too once I get to the unit, just ask our manager more, see how they're partnering with the community. Because I just feel like with pregnancy and just OB in general, since it's such a long time that we have a relationship with the patients, all through like prenatal care and delivery, and then the time afterwards, I just feel like it's really important to have that community emphasis. So I'll try and find out some more information as well.
Wonderful. So I know Chelsea or Logan, we're coming upon time. We want to be respectful of people's time. If there's no other burning questions, then I think we'd want to encourage everybody to just engage this work, spend some time dealing with the concepts around inequality and equality and justice, get very comfortable with how they show up in different arenas, and then more importantly, how you address those issues from a systemic and even a tactical approach. That's going to make you a stronger professional, whether it's health profession or any profession. You're just going to be a better advocate and resource for your stakeholders.